Welcome back to Decode Healthcare with Harshal. Today, we're jumping right into a brand new explainer on the clinical settings that define your evaluation and management code selection. Look, the room your patient is sitting in, it isn't just a physical backdrop. It fundamentally changes the rules, the code sets, and your audit risk. Getting this wrong doesn't just mean a denied claim, it means a serious financial sting. Let's get into it.
Here is our roadmap for this explainer. We're going from the EM code landscape to office and outpatient settings, inpatient and observation care, the emergency department, and finally, consultations and critical care.
Section 1. The EM code landscape. So, the very first distinction you've absolutely got to master is the difference between non-facility and facility settings. A non-facility is somewhere like a private clinic or a standard office setting where you are doing professional coding. A facility, on the other hand, refers to hospital-based encounters. And guys, here is a strict boundary you literally cannot cross. These codes are simply not interchangeable. You can't just take an office visit code and drop it onto a hospital claim without risking immediate audits and denials. No way.
To pick the exact right code, you always need to triangulate 4 key factors. First, the setting of the service, which is what we're deeply focused on today. Second, the patient type. Mainly, are they new or established? Third, the level of service, which naturally scales up as clinical complexity increases. And fourth, the selection method. Remember, you must choose whether you are using medical decision-making, or MDM, versus total time spent to score that visit. They are mutually exclusive per encounter.
Moving on to Section 2, office and outpatient settings. In the office setting, the absolute golden rule is the 3-year rule. This strict definition dictates whether you bill from the new patient bucket or the established patient bucket. So a patient is only classified as new if they haven't received any professional, face-to-face services from you or another physician of the exact same specialty in the exact same group practice within the past 3 years. Seriously, even if 2 doctors share a waiting room and a coffee machine, if their specialties are different, a patient established with one is technically brand new to the other. Kind of wild, right? Now, the 992002 through 99215 code range handles your standard clinic visits, but the rules actually stretch to accommodate modern care delivery. If you're doing remote evaluations via audio or video on platforms like Zoom, well, telehealth guidelines apply. And if the provider is traveling to the patient's residence, we shift to a completely different code range altogether, 99341 to 99350. The setting absolutely drives the code.
Let's see this in action. Say we have 2 patients seen in an urgent care facility. Patient A is just here for a simple follow-up for mild hypertension. The provider reviews a blood pressure log, doesn't change any meds, and the visit takes about 10 minutes. That's low medical decision-making, which gets you a 9912 code. But now compare that to patient B, who comes in with new onset chest pain. The provider does a full history, orders an ECG and labs, considers diagnoses like angina versus GERD, and spends 30 minutes. That requires moderate to high MDM, pushing the code up to a 99214. Basically, the higher the medical decision-making, the higher the code level and the reimbursement.
All right, Section 3, inpatient and observation care.
For codes 99221 through 99239, we're combining both inpatient and observation services. This umbrella covers initial care, subsequent daily care, and discharge services. It even includes temporary hospital stays where the patient is just under observation status. But listen closely, because here is a massive red flag for compliance. Your code selection completely hinges on the official admission status. Making sure the provider's documentation clearly supports whether the patient was officially admitted versus just observed is absolutely critical for audit readiness. You absolutely must avoid billing observation codes if the patient's record shows they were formally admitted.
Let's break that down to make it crystal clear. Scenario 1. A 68-year-old patient is formally admitted for a congestive heart failure exacerbation, and the MDM is high. Because of that formal admission status, this hits code 9923 for initial hospital care. Now, Scenario 2. A 54-year-old is placed in observation for chest pain, ruled out for an MI, and discharged on the very same day with moderate MDM. Because they were never formally admitted and it all happened in one single day, that falls under 9925 for a same-day observation admit and discharge. Make sense?
Section 4. The emergency department. The emergency department is totally unique in the EM landscape. Why? Well, because the concepts of new versus established patients do not apply here at all. Literally doesn't matter if you've seen the patient 50 times or if they just walked in off the street for the very first time. The ED is a facility meant for unscheduled, immediate care for acute illnesses or injuries, so the coding structure completely ignores that 3-year rule we talked about earlier.
For the ED codes ranging from 99281 through 99288, the level of service is determined solely by medical decision-making. Time is not a descriptive factor here. It just scales up from straightforward issues to highly complex emergencies. So a straightforward, simple dressing change, that's a 99281. A moderate complexity issue, like severe abdominal pain or a migraine, brings you to a 99283. And if the physician is actually directing advanced life support via two-way communication with EMS, you'd use code 99288. The physician just has to document the evaluation and management process to justify whichever MDM level they choose.
Finally, Section 5, Consultations and Critical Care. When another provider specifically requests an evaluation, an opinion, or advice regarding a patient, that's when we use the consultation codes. These are uniquely split up. If the consultation happens in an outpatient setting, you'll use codes 99242 to 99245. If it's an inpatient setting, it's 99252 to 99255. But remember, and this is key, the cornerstone of these codes is that documented request from another provider. Without that specific request for an opinion, you're just coding a standard visit.
Now, when dealing with life-threatening critical care, the rules change again. Here, we strictly code based on total time spent in direct, continuous management of the patient. For the first 30 to 74 minutes of direct critical care, you build a base code, 99291. For each additional 30 minutes of care beyond that first hour block, you build the add-on code, 99292. So if you have a patient in septic shock requiring 90 straight minutes of management, you would bill 1 unit of 99291 and 1 unit of 99292.
Because these codes cover intense, life-saving interventions, the documentation standards are extremely high. The provider has to clearly document the patient's critical condition, things like shock, organ failure, or severe respiratory distress. You also cannot report these concurrently with other EM codes for the same time block. Plus, things like reading blood gases, monitoring pulse oximetry, or managing a ventilator, those are already bundled in. They're considered part of the critical care work and cannot be billed separately. In other words, please don't double dip on your claims here.
So take a moment to reflect on how recognizing the strict boundaries between the office, the ED, and the ICU will completely bulletproof your billing. Matching the correct code family ensures accurate reimbursement, and trust me, it keeps the auditors away. But I'll leave you with this question to ponder. Are you leaving money on the table, or worse, inviting an audit just because of the room your patient happens to be sitting in? Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.